So this was matched indirect treatment comparisons of two JAK inhibitors compound, one currently approved in patients with myelofibrosis and platelets less than 50,000, Pacritinib, and then one just recently approved with patients with myelofibrosis and anemia called Momelotinib. So both of these agents are JAK inhibitors, but Momelotinib primary action is also inhibition of something called ACVR1, which is activin-like receptor. And it has been also found out that Pacritinib does provide the same mechanism of action. However, that was not known at the time of its approval or exploration. So this study focused on comparing the safety and the anemia responses of both of these agents, as we really needed a patient's help with anemias where we had no drug approved. Again, as mentioned, Pacritinib is approved for those with platelet less than 50,000. So this study took data that were available on the domains and published from Pacritinib randomized or phase 3 clinical trials, particularly something called PERSIST-2 or PAC203. And then it also took available data from Momelotinib, 3 phase 3 studies, Simplify-1, Simplify-2, and Momentum. There's something to point out that it actually combined populations of patients that were either JAK inhibitor exposed or JAK inhibitor naive, because the study conduct mixed these patients in a various study. So both of the data were weighted against the most important clinical characteristics. So we had the comparable populations, although these also represent the biggest limitations of the study, because not all of the data were published or available with the same criteria or to the same extent. That means that we could only compare mixed population of patients with exposure as well as not exposure JAK inhibitor together. After the weighting, we came up with a very comparable patients group that had a quite effective sample size for the safety, which was comparing the most frequent side effects that occurred in all of these agents in more than 15% of patients. The effective sample size remained about hundreds on each side. And then for the anemia responses, which basically primarily compared the data from PERSIST-2, then we had an effective sample size about 50 on each side. There was no possibility to weight in anemias at the baseline, because these patients are more commonly seen in Momelotinib studies, but not Pacritinib. That would significantly decrease the effective sample size for this comparison. So bottom line, what we have seen was that Momelotinib showed more safety in terms of major grade 3 adverse events, as well as serious adverse events and adverse events related to gastrointestinal toxicity, such as nausea, diarrhea, vomiting, and as well showed superior or favorable odds ratio for most common grade 3 hematologic toxicity, including anemias, thrombocytopenias, or neutropenias. And actually, interestingly, there were no a single comparison that Momelotinib would basically show to be less favorable in compared to Pacritinib. So the study basically compared the odds ratio as well as risk difference between these two agents and came up with the same conclusion, that Momelotinib represents a very viable and favorable treatment options for patients with myelofibrosis that were or were not exposed to JAK inhibitors, and in comparison to Pacritinib also offered a favorable safety profile, especially for gastrointestinal tolerance as well as hematologic. I think particularly was important to see the safety and the tolerance, which sometimes is an issue with Pacritinib, which is, however, a very good JAK inhibitor. And then interestingly, because it was also discovered to be ACVR1 inhibitor, actually shown even to be more potent than Momelotinib, the anemia data, which only has approval for Momelotinib, are very interesting. So we have to learn where to place both of these agents. However, they have a little different approvals, where Pacritinib has restrictions for platelets below 50,000, Momelotinib has been actually tested in clinical trials, especially the last one, Momentum, that included patients up to platelets 25. So actually, the scale of populations between 25 and 50 is still eligible for both agents. So I think here we will be definitely going based on the safety and tolerability. However, the anemia responses that we have seen with momelotinib seem to be a little higher than those we've seen with pacritinib, although the mechanism of these agents is reported to be very similar. So that's something that we'll have to learn in clinical practice, how to best sequence these patients and these agents in terms of patients' responses. And again, as I mentioned, because the comparison could be only indirect and had to mix patients with newly diagnosed disease as well as patients that were previously exposed, however, we define it JAK inhibitors, that is also something to be found in the clinical practice in terms of the efficacy, because we don't have efficacy head-to-head comparison between these two agents. So if safety is not the concern and patients could tolerate these agents, efficacy is going to be the next one we're going to be learning about. I think it's fantastic that we have a number 4 JAK inhibitor. It's really good that it has a very broad indication for patients with myelofibrosis and anemia, where we haven't had actually any JAKs in it. One thing to highlight is that pacritinib is approval for platelets below 50,000, but it rarely does improve the platelets, as people would normally think about, I'm going to use these agents to achieve platelets improvement. That's not commonly the case. It stabilizes the platelets and allows to treat the patients for the spleen and symptoms, but it will not significantly increase. Of course, there could be some anecdotal patients, and I have few of those as well, but it not in general increase the platelets number. Whereas pacritinib does improve the anemia and does make people transfusion independent. That has been actually seen in some of the studies up to 60+% of patients, which is a remarkable findings we have seen in certain situations of this. On average, it's about 30 to 50% depending on what population of patients we have and what criteria we use. But that is something to keep in mind, that we will not have a platelets improvement, and I don't think with any of these agents on a general scale, but the anemia improvements has been very significant in momelotinib.